Hello and welcome to the CME Lunch Hour program. My name is Lori Green and today's topic will be on the duplex evaluation of renal artery stenosis. We will be discussing both the direct and indirect methods for evaluating renal artery stenosis today, and so let's get started with our first slide. I'm frequently asked if we should include the Doppler evaluation of the renal arteries with a routine renal ultrasound. And the answer to that question is no. You may want to use the Doppler during your renal examination to differentiate hydronephrosis from enlarged hilar vessels or to evaluate tumor vascularity, but renal artery evaluation is only performed when the exam is specifically requested to evaluate patients who have had uncontrolled hypertension. Now, when an exam is requested for a renal artery stenosis evaluation, it is important that you include a normal renal sonography examination to evaluate the size, shape, echogenicity, and any abnormalities of the kidney. And a bilateral examination should be performed, and if any abnormalities are seen, this should be taken into consideration when evaluating waveform characteristics and the quantitative criteria. So as a review, the normal ultrasound of the kidney should reveal a length of anywhere between 8.5 and 15 centimeters and a width measurement of 4.5 to 5 centimeters. We also will look at the overall echogenicity of the kidney, and it should be less echogenic as compared to the liver or the spleen. We will also include a measurement of the cortex thickness, and typically the normal cortex will measure greater than 1.1 centimeters. Now this next slide will reveal an examination of the left kidney and the spleen, and we can see from this examination the normal echogenicity of the spleen is very similar to that of the liver, a medium level gray echogenicity, and just adjacent to the spleen we see the left kidney. Now this is a sagittal view of the kidney, and this darker area outlined by the arrow is the cortex of the kidney, and the innermost hyperechoic area is the medulla. The medulla is comprised of the renal pyramids and the blood vessels, and the various interfaces of these structures blend together to comprise a very bright echogenicity. Typically, the cortex of the kidney should be less echogenic as compared to the spleen, and we would take measurements of the cortex thickness and see that it measures 1.1 centimeters or greater. We also, in the normal exam, will take measurements of the length of the kidney. In a sagittal view, you want to rotate the transducer so that you get the longest length of the kidney and then measure from one end to the other, superior to inferior, and that measurement should be between 8.5 and 15 centimeters. And then a transverse scan plane at the mid-level of the kidney, you would measure right at the where the renal vessels are going into the hilum of the kidney, and that should be measuring around 4.5 to 5 centimeters. We want to take a look at both the right and left kidneys and compare them to make sure that they have similar size, shape, and echogenicity. And we also want to look to see if there's any tumor present or if the patient has hydronephrosis or any other abnormalities. When we have an abnormal renal ultrasound, one of the things that we'll be looking for is a length difference of 2 centimeters or more. A difference of 2 centimeters may indicate that the patient has a renal artery stenosis on the side of the smaller kidney. Also, in renal abnormalities, we might see that the echogenicity of the kidney is greater than the liver, and this is also considered to be abnormal. And of course, cortex thickness less than 1.1 centimeters, as well as bilateral small kidneys, would be an indication that there is some renal disease. Now, this is an example of an abnormal renal examination. This is view of the right kidney and the liver. The liver has a normal echogenicity that's nice and homogeneous and a medium level gray echogenicity. And just inferior to the liver, we see a transverse scan plane of the right kidney. In the transverse scan plane, the kidney should be fairly rounded in appearance. The first thing that you should notice is that the echogenicity of the kidney itself is much brighter or hyperechoic as compared to the liver. So this is abnormal. In addition to that, There are multiple anechoic structures within the kidney itself, and we've taken a measurement of one of these cysts here that measures 19.4 millimeters by 12.6 millimeters. In the event that you would see that there is an abnormality of the kidney, it's important to note that because it will possibly have an impact on the Doppler evaluation when you get to the renal arteries. Now, the reason that we would be performing a renal artery stenosis examination is to evaluate patients who have had a history of uncontrolled hypertension, and the physician is trying to find the source of that hypertension. In some patients, the hypertension is actually due to a renal artery stenosis. The kidney plays a dominant role in blood pressure regulation by its influence on circulating plasma volume and vasomotor tone. Within the kidney, there's a very complex feedback mechanism that's referred to the renin-angiotensin system. And this system helps to maintain homeostasis or balance by regulating the body's sodium-potassium balance, the fluid volume, and blood pressure under varying physiologic conditions such as stress. The nephron is the structural and functioning unit of the kidney. Whenever there is an underlying cause that disturbs the vascular perfusion to the nephron, then that can cause the renin-angiotensin system to be activated and results in renovascular hypertension. So what patients would be considered for renovascular hypertension? Those patients would be considered to have a diastolic blood pressure that's greater than 115 millimeters of mercury, and those patients who have a history of atherosclerosis or patients who have fibromuscular dysplasia. There's also a strong clinical association with renal artery stenosis and cigarette smoking. So our hypertensive patients who are smokers, they may be a candidate for a duplex evaluation to determine if they have renovascular hypertension. Other patients that might fall into this category are patients that have an epigastric bruit. Studies have shown that 46% of the patients that have renovascular hypertension have an epigastric bruit as compared to those patients who have essential hypertension, where only 9% of those patients will have an epigastric bruit. Now, atherosclerosis is the most common etiology of renal artery stenosis. It's very frequently seen in men, and it usually occurs at the origin. However, we can have tandem lesions that occur within the vessel, or we may have just an isolated distal stenosis. So when we're evaluating the renal arteries utilizing the direct method, it will be very important that the entire length of the renal artery is evaluated from its origin all the way to the hilum of the kidney. The other primary etiology of renal artery stenosis is fibromuscular dysplasia. Approximately 40% of patients that have renovascular hypertension will have fibromuscular dysplasia. In the literature, you'll see that it's generally thought to occur more frequently in females that are between the ages of 30 and 40 years. And fibromuscular dysplasia more frequently affects the distal aspects of the artery, and it's characterized by arterial wall thickening alternating with small aneurysmal dilatation. So it actually has kind of a beaded appearance to it when we look at it on angiography. And sometimes you'll hear the term string of beads effect, and that is the classic characterization of fibromuscular dysplasia by angiography. It is the most, medial fibroplasia is the most common form of fibromuscular dysplasia that we see in patients with renal artery stenosis. Now, it's important to realize that renal artery stenosis and renovascular hypertension are not synonymous. Just because we detect a renal artery stenosis does not prove that that is the source of the patient's hypertension. So the purpose of the examination is first to detect the presence of a stenosis. And then once the stenosis has been detected and determined that it is a stenosis greater than 60% diameter reduction, then that patient would probably move on to angiography to confirm. and then would have the stenosis repaired. Once the patient has gone to surgery, if the hypertension completely resolves or dramatically improves after surgery, immediately after surgery, then that proves that that patient has renovascular hypertension, and the renal artery stenosis was the source. Now, a dramatic improvement in hypertension would be where the blood pressure returns back to a level at least at 140 over 90 millimeters of mercury immediately post-op. Now, if the patient goes to surgery and the hypertension does not resolve or dramatically improve, then that patient is categorized as having essential hypertension. Essential hypertension is hypertension that develops without an apparent cause. And so you may be wondering, well, why do they have renal artery stenosis? And basically what happens is that particular patient has developed a renal artery stenosis as a consequence of the hypertension. Now, when we look at the total population of patients who actually have renal vascular hypertension, only about 5% of the hypertensive population actually has renal vascular hypertension. So you may be wondering, why are we going through all the trouble of performing a non-invasive examination that takes anywhere between an hour and 2 hours to perform when only 5% of the patients are going to be diagnosed with this condition? And the primary reason that we're doing the examination is, number one, it is non-invasive, and it can determine whether the patient has a renal artery stenosis without having to put them through an angiography. And secondly, patients that are treated medically for renovascular hypertension, that have renovascular hypertension, have an increased incidence of renal failure and much shorter lifespans. So if we can non-invasively detect and repair a renal artery stenosis in patients who have renal vascular hypertension, we can significantly minimize the complications that are associated with these patients who have been treated medically for this condition. So now that we've talked a little bit about the applications of duplex evaluation of the renal arteries, we've talked a little bit about the different types of hypertension and the reason that we evaluate renal arteries for patients with hypertension, let's talk a little bit about the different methods. The direct method of evaluating renal artery stenosis is where we look directly at the main renal artery from its origin all the way to the hilum of the kidney. Now, this particular examination would require most of your evaluation being performed with the patient in a supine position in a transverse scan plane. And if we think about the anatomy of the renal arteries, the main renal arteries will arise off of the posterior lateral aspect of the abdominal aorta. In this particular examination here, we're in a transverse scan plane. This would be anterior. This is the spine, posterior. This is the abdominal aorta. The blue vessel color encoded in blue is the inferior vena cava. And the right renal artery comes off of the lateral aspect of the aorta, coursing posterior to the inferior vena cava. So we can see the right renal artery that has been color encoded in red here, coursing just posterior to the IVC. Now, the Doppler evaluation of the renal artery would require that we look especially at the origin of the vessel and follow and taking samples along the entire length of the renal artery. Now, one of the pitfalls of the direct method is that it's very difficult at times to get a good Doppler angle at the origin of the vessel because of the angle at which the vessel arises off of the aorta. You can see right here in the mid-segment of the renal artery that we can get a pretty good Doppler angle, but right here at the origin where we usually see the majority of atherosclerosis develop, it's very difficult at times to get a 60-degree or less angle to flow. And so that's one of the pitfalls and challenges to doing this examination. Now, the left renal artery, we can see it coming off of the posterior lateral aspect of the aorta here, and because we have blood flow going away from the transducer, we have chosen to leave the color encoded to blue going away from the transducer or red going towards the transducer. So although this is an artery, we see that it is color-encoded blue because flow is going away from the transducer. And just as a note, typically in the abdomen, we tend to be Doppler purist, and we use the BART format with color flow direction encoded with blue, flow going away from the transducer, color encoded in blue, and flow going towards the transducer as color encoded in red. So for those of you who are used to doing carotids and peripheral vascular applications where we make our arteries red and our veins blue, that's not always the case in the abdomen. Many laboratories choose to be Doppler purist because the vessels in the abdomen are coursing in a lot of different directions, and sometimes it's very difficult to get the same vessel to remain the same color throughout its entirety. But in this example here, we're looking at the left renal artery, and one thing that you can notice is that the angle at which the left renal artery comes off of the aorta is a little bit different as compared to the right, and so it's not quite as difficult to get a good angle of incidence of 60 degrees or less to the left renal artery as it is on the right. Now, there is an alternative view that you can use to the transverse skin plane, and this has been commonly referred to as the banana peel sign. And basically what we do in this view is we roll the patient up into an LPO position, and we place the transducer along the right lateral aspect of the patient's body, and we angle or direct the sound beam towards the patient's left side of the body. So in doing that, what we will see on our ultrasound image is the liver first, because that's the structure our sound wave interacts with first. And then as the sound beam continues towards the patient's left, it will interact with the inferior vena cava, so that's what we're seeing here, color-encoded blue. And then, as the sound beam continues leftward, it will interact with the abdominal aorta. So in this view, what we're showing is the abdominal aorta at a slight angle, and these two red vessels are the right renal arteries coursing posterior to the inferior vena cava. This particular patient has a very common vascular variation where they have two main right renal arteries. So it's very common. About 20% of your patients will have duplicate or multiple renal arteries. And using the direct method, you must evaluate all of the renal arteries. So if they have duplicate renal arteries, you're going to be evaluating both renal arteries in their entirety. Now, in this particular view, you can see with the sound wave coming in that the blood flow would be going towards the transducer, so the right renal arteries are color-encoded in red. This blue vessel right here is the left renal artery coming off the left side of the aorta, and so it has flow going away from the transducer, and it's color-encoded in blue. So in this particular view, even though we're seeing both the right and the left renal arteries within the same scan plane, they are actually color-encoded differently because of the flow direction. The key factor that you need to notice in this particular image is that by utilizing this view, it allows you to get a good Doppler angle at the origins of the right and left renal arteries almost at a 0-degree angle. It is important when you go to do your Doppler evaluation that you do place your angle cursor within the vessel and you rotate it so that it's parallel, the angle correct is placed parallel to the vessel walls so that the velocity calculation is correctly calculated. Okay, so we talked about what view that we're going to be evaluating these patients in. We have the choice of a supine transverse scan plane. If by chance the patient is obese, which many of our renal artery patients are, or they have a significant amount of bowel gas that's interfering with your examination, an alternative view would be to roll the patient up into an LPO position and go for the banana peel sign to evaluate the origins of the vessels. But in order to interrogate the remainder, the mid and distal aspects of the main renal artery, you would again have to put the patient back into a supine position. So what are the normal characteristics that we'll be looking for in the evaluation of the main renal artery? So this is the direct method of directly evaluating the main renal artery. We're going to look for a peak systolic velocity, so we're going to take a velocity measurement at the origin of the vessel, at the mid-segment and distal aspects of the renal artery. And we're looking for a peak systolic velocity to be somewhere around 100 centimeters or less, depending upon the patient. If you have a young patient that has a lot of very compliant arteries, then you might see that their velocities might be slightly higher. Our waveform characteristics should be low resistance in characteristics, and we should see a nice clean window underneath our systolic peak. In addition to the peak systolic velocity measurements, we'll also be doing a resistive index, or RI, and in the normal patient that should be less than 0.75 or 75%. And we'll also be doing a renal to aortic ratio measurement. And that is obtained by taking a peak systolic velocity in the proximal abdominal aorta, and then another peak systolic velocity at the maximum site of stenosis, which will typically be at the origin of the vessel, and calculating a ratio measurement. And that should be less than 3.5 in the normal patient. So let's take a look at a waveform from a normal examination. In this particular example, we're actually taking the spectral Doppler in the mid aspect of the renal artery. If you look at the image here, we see that we have the vessel color encoded in red, so we have inverted our color display on this particular patient. Where I'm pointing to with the arrow is the abdominal aorta, so this is the origin of the renal artery, and then we're down into the mid-segment. Notice also that we have placed the angle cursor within the vessel, placing it parallel to the vessel walls so that we accurately measure the angle of incidence. And in the upper left-hand corner, you can see that we're at an angle of 56 degrees. So we are at an optimal Doppler angle, less than 60 degrees. And in doing so, we look at the spectral Doppler and we see that we have a nice sharp rise to systole and a gradual deceleration down into diastole. We see a nice clean window underneath both the diastolic and the systolic components of the spectral tracing. This is a classic low resistance waveform pattern that demonstrates good flow throughout the entire cardiac cycle. Our zero baseline on this display has been moved down to the bottom of our scale here. So just looking at the waveform characteristics itself, we initially know that this patient has a normal waveform because we have a low resistance waveform pattern. The next step is to get some quantitative information. And as we mentioned before, we want to take a peak systolic velocity, and that's been indicated here by the caliper that's been placed at peak systole. And on the right-hand side of our tracing, we see that the peak systolic velocity in this patient is 90 centimeters per second, which is well below our 100 centimeters per second standard for normal patients. The next measurement that we would do is a resistive index, and that measurement is performed by placing the cursor at peak systole and at end diastole right before the onset of the next systole. We input this into the systems calculator, and it measures in this patient that its resistive index is 0.53, which is also well below the normal value of 0.75 or less. In addition to those two measurements, we then would do a renal to aortic ratio. Now, as I mentioned before, the renal to aortic ratio is measured by taking a velocity in the proximal segment of the abdominal aorta. Typically, that will be above the level of the renal arteries, right around the celiac or superior mesenteric artery level. We'll insert that into the system's computer, and then we will take another measurement at the maximum site of stenosis, where we get our highest velocity in the main renal artery. Once that has been inserted into the system's computer, it will measure a renal to aortic ratio. And if you were to do this by hand, you would be taking the value from the main renal artery, the maximum site of stenosis, and divide the aorta into the renal artery stenosis velocity to calculate your renal to aortic ratio. And that value should be less than 3.5. So if you have all of those values present, a low resistance waveform pattern, a nice clean window, a peak systolic velocity that's 100 centimeters or less, a renal to aortic ratio that is 3.5 or less, and a resistive index that's less than 0.75, then those are all criteria that point to a normal examination. Now, if the patient has an abnormal examination, then we would be seeing that the renal to aortic ratio is greater than 3.5, and that just distal to the site of stenosis that we would have some degree of turbulence depending upon the degree of stenosis. Typically, the more significant the stenosis, the more significant the distal turbulence. And on real time and using color, turbulence is usually seen as a mosaic pattern where we have a mixture of reds and blues and greens and yellows mixed together. And sometimes just identifying the turbulence is sometimes your first clue that you actually even have a significant stenosis. Now, the values on the peak systolic velocity may vary depending upon what type of angle you're able to get. As I mentioned before, one of the pitfalls of the direct method is that it's very difficult to get an angle of 60 degrees or less at the origin of the main renal artery, where we typically see the most significant stenosis. So the literature will state that the peak systolic velocities that are greater than 150 centimeters per second using an angle of 60 degrees or less would be suggestive of a stenosis that's greater than 60%. And that's the criteria that would be considered a significant main renal artery stenosis that would be a source of renovascular hypertension. Unlike the carotids and peripheral vascular applications, we don't categorize our stenosis into various categories. What we're primarily interested in is the stenosis greater than 60% or is it less than 60%? If it's greater than 60%, then there's a chance that that's the source of the renovascular hypertension. If it's less than 60%, yes, they have a stenosis, but it's probably not the source of their hypertension. So that's kind of our magic number that we're looking for is the stenosis greater than 60% or not? And that's what these values are pointing towards. So if you have an angle of 60 degrees or less, then we're looking for a peak systolic velocity of greater than 150 centimeters per second, combined with a renal to aortic ratio that's greater than 3.5 and associated distal turbulence. However, if you have one of those many patients that were at 65 degrees or maybe 68 degrees angle of incidence, then we have to bump that peak systolic velocity up to greater than 180 centimeters per second in order to categorize it into greater than 60% stenosis. So this is an example of a patient that has a greater than 60% stenosis. First off, you'll notice that our artery is color encoded in blue. So in this particular patient, the sonographer is a Doppler purist, and we're actually showing flow as it truly is in regards to the Doppler beam. So we're showing the left, I believe this is the left renal artery, yes, coursing off of the abdominal aorta, flow going away from the transducer, so it's color encoded blue. Also, the corresponding spectral tracing is being displayed below the zero baseline because it's going away from the transducer. So it looks a little odd, but in a Doppler purist fashion, this is how you have to get used to looking at it. We also notice that the angle cursor has been properly placed within the vessel so that it's parallel to the vessel wall. And so we double check that our angle is less than 60 degrees, and it is. It's 53 degrees. When we measure our peak systolic velocity, we see that it's 243 centimeters per second with an end diastolic velocity of 37. And you can notice that the diastolic velocity, the diastolic component of the waveform, is not quite as great as we see in the normal patients. Usually it's a little bit more generous. And the renal to aortic ratio in this patient was greater than 3.5. So a peak systolic velocity of 243 centimeters per second, that's more than double the normal value, combined with poststenotic turbulence and a renal to aortic ratio of greater than 3.5, would indicate that this patient would fall into a category of a stenosis greater than 60%, and this would be a candidate that would go on to have further evaluation by angiography. Well, the evaluation of renal artery stenosis by the direct method can be very time-consuming, and in the early stages of learning how to do these examinations may take you up to 2 hours to do an examination. And due to the long examination times combined with the pitfalls of difficulty in obtaining good Doppler angles and having to evaluate the entire length of the vessel, was motivation for trying to find an alternative method for evaluating these patients that would be a little bit easier technically, but yet provide the same level of accuracy as the direct method that's been around for so long. Dr. Stavros from Denver, Colorado has published the majority of the information on this particular method, and it actually involves looking at the vessels within the kidney versus looking at the main renal artery. And so looking at the anatomy within the kidney, we see that we'll be evaluating once the once the main renal artery enters into the hilum of the kidney, it then divides into the segmental renal arteries. And then the segmental renal arteries divide into the interlobar arteries. And the interlobar arteries actually course adjacent to the renal pyramids. And right about the point of the top of the renal pyramids, the interlobar arteries will then again divide into the arcuate arteries that course along the top of the pyramids. And then the arcuate arteries will then divide into even smaller vessels referred to as the interlobular arteries, and they course out to the periphery of the kidney. With the indirect method, we will be taking a minimum of 3 samples of the segmental or interlobar arteries within the kidney. The theory behind this examination is that if we have a significant stenosis of the main renal artery at its origin that's greater than 60%, then that would affect perfusion to the kidney distally, and therefore we would see changes in waveform characteristics and also in time measurements in these vessels that are in the distal vasculature. Now, the technique for performing the examination for an indirect method would involve rolling the patient into an LPO position, placing the transducer directly over the kidney so that we have very little liver or spleen in view, depending upon which kidney that you're utilizing. The whole goal is to get the kidney as close to the transducer as possible so that we don't have to deal with effects of attenuation and we can get good Doppler signals. We also are going to have to change our system settings on our machine so that we sensitize our Doppler for low flow. We're now dealing with very small vessels that are within the kidney as compared to the main renal artery, and therefore we're going to be dealing with smaller Doppler shifts, a little bit lower flow velocities, and so we'll have to sensitize our machine to low flow. We do this by reducing our PRF, which is also known as scale or velocity range, depending upon the system that you use. And so that will make our waveform a little bit bigger so that we can look at subtle changes in the waveform characteristics that we'll be discussing momentarily. We also will be adjusting changes in our sweep speed. Typically, when you turn on a machine to do a Doppler examination of the carotid, peripheral vascular, or abdominal vasculature, the sweep speed of your spectral Doppler will default to about 4 cycles per second. What we'll want to do in the renal indirect method of the renal arteries is to increase that sweep speed a little bit faster, so we might only see 2 cycles per second. But what it will allow us to do is to actually stretch that waveform out so that we can see subtle changes in the waveform characteristics. As you'll soon see, we're not going to be as concerned with actual velocity calculations in this particular technique. What we're going to be putting our primary emphasis on is waveform characteristics and time measurements. So what are we going to be looking for in the normal patient? What we'll what we'll be looking for is when we put the color over our kidney initially, that we see flow that extends all the way out to the margins of the kidney. We shouldn't see any areas of absent flow. And the flow should be fairly continuous. We shouldn't see it flashing at us in a high resistance pattern, but it should flow throughout the entire cardiac cycle. If we see any areas where there's no flow, then that would indicate a possible segmental arterial occlusion, but most of the time it's usually a source of poor Doppler angle. And I'll show you what I mean here on this next slide. We have the color Doppler placed right over the right kidney, and we actually can see the liver here. I would actually, we're getting good color flow in this particular example, but if you find that you're not getting real good color and you've got a lot of liver in view, you might want to roll the patient up a little bit more, come out a little bit more lateral with your probe placement, and get rid of some of this liver so that the kidney takes up almost the entire view on your image. In this particular example, the patient has really good perfusion, so it wasn't as necessary to do that. And what you can see right off the bat is that there is excellent flow all the way out to the periphery of the kidney. So this kidney is well perfused. The only area that we don't see a lot of flow is right over here in this area, and we see that there's a couple little segmental vessels coming out laterally, but we don't get as full of filling as we see in some of the other segments of the kidney. And if you look at the angle at which these vessels are coursing, compared to our Doppler angle coming in, we're really at about a 80-degree angle to flow there, and so that's the probable source of lack of flow in this area. So what you would want to do in this particular patient is, after you get done evaluating the areas that we can see well from this approach, then come in maybe from a different approach and make sure that you can get good color filling in this area. So right away, when you put on your color and you see that kidney light up and it has flow all the way out to the periphery, you got a pretty good idea about the perfusion of that kidney. They get good flow all the way out to the edges. We're probably going to see normal waveforms in this particular example. On the other hand, if you see that the flow does not extend all the way out to the margins, or you have absent segmental flow, then that right away is an indication that you're going to have some abnormal waveform characteristics, and this patient may very likely have a significant renal artery stenosis. This particular slide right here is demonstrating that we put the color on, but we're only seeing flow extending only to about midway into the kidney. There's no flow all the way out here towards the cortex of the kidney. And in real time, this would be flashing at you, red, blue, red, blue, red, blue, in a very high resistance pattern. And if the key here is that if you see that you've got flashing of flow at you, then you're going to want to check to make sure that you've sensitized your machine for lower velocity flow. So we can do that right now. We check over here to the upper left. We see that the pulse repetition frequency is set at 900 hertz. Typically, we would have it adjusted around 1,000 to 1,500 hertz for the indirect method. If we were doing the direct method, where we evaluate the higher velocity pulsatile flow in the main renal artery, that PRF would probably be set around 2,000. So it's about half the value when we're doing the indirect method. So we have a pretty low PRF, and then we look at our wall filter settings, and we can see that we're all the way down to 15. So we've actually reduce that down to the lowest setting that this system will allow you to go, to make sure that this lack of perfusion to the kidney is not a technical error as compared to being a true abnormality. Now, once we've assessed the perfusion to the kidney, we then are going to look at waveform characteristics. In the normal segmental renal artery, what we're looking for is a waveform that has a sharp rise to systole, has an early systolic peak. You'll notice in this example that there's actually two systolic peaks. We have end diastole, the onset of systole, our first systolic peak, kind of dips down, and then we have a second systolic peak, and then a gradual deceleration down to diastole. So the waveform should be fairly low resistance in pattern, so we should have diastolic flow, but we should see two systolic peaks, and the key is this early systolic peak. And that's the reason why we have to sensitize our machine to low flow. We want to make our waveform a little bit bigger. That's achieved by lowering your scale or velocity range. And we want to have our wall filter settings down to at least 25, but you may have to go lower if your system will allow you to do so. And you want to increase your sweep speed to 2 cycles per second to stretch the waveform out, because sometimes this little early systolic peak is difficult to assess, and in some patients you really need that little extra help in sensitizing your machine to actually even see the early systolic peak. Now, as you look at the example right next to my normal pattern here, you'll notice that when we have an abnormal signal where we have a stenosis that's 60% or greater, the first thing that happens is we lose that early systolic peak. So now all we have is 1 systolic peak instead of 2. That's your first indication, after the color flow being abnormal, that you definitely are going to have an abnormal exam. And as the stenosis becomes more significant, greater than 60% and even closer to 90%, you'll see that your waveform becomes very dampened, and there's very almost a 1-to-1 ratio between systole and diastole. Now, when we look at a spectral tracing here from a normal examination, first thing we see on our image is that we have very good perfusion all the way out to the periphery of the kidney. And in our sample, the segmental renal artery, we see that we have a very good signal. It's low resistance in nature. We see flow occurring throughout the cardiac cycle. And the next thing that we see is, as we look at the characteristics of the waveform, we see the early systolic peak right here, and then the second systolic peak. So we have a low resistance waveform pattern and the presence of an early systolic peak. Now you might notice that there is waveform window filling both under diastole and systole. When we're looking at the segmental renal vessels or the interlobar vessels, these are very small vessels, and the sample volume size actually covers almost the entire vessel from wall to wall. So we will see window filling both in systole and diastole under normal situations in these vessels just due to the size of the vessel compared to the sample volume size. So window filling is not really a diagnostic criteria when we're doing the indirect method. Well, now we've got good we have good perfusion to the kidney by color. We have a waveform characteristics that's low resistance. We see that we have an early systolic peak. And the final piece of the puzzle is to do a measurement of the rise time or acceleration time. And that's performed by placing the cursor at end diastole and at the early systolic peak. And what that's going to do is measure the time that it takes for flow to get from end diastole to the early systolic peak. And that number should be less than 0.07 seconds. And as you can see on this machine, it's actually labeled as RT for rise time, and it's 0.04 seconds, well below that normal value of 0.07 seconds. Some machines will actually indicate this measurement as AT for acceleration time. It's the same thing. Other machines might actually give you a little triangle, which is delta T for change in time. Any of those are actually measuring the time that it takes from end diastole to the early systolic peak. And the theory there is that if you have a significant renal artery stenosis at the origin of the vessel, then that's going to affect the time that it takes flow to get to the distal vasculature. So if you have a significant renal artery stenosis, the rise time is going to be longer. And in addition to that, you will lose your early systolic peak. So this is a very normal patient. An abnormal spectral tracing would indicate that you have an acceleration time that's greater than 0.07 seconds combined with an absent early systolic peak, and you may or may not see changes in your resistive index. Most of the time, you will actually see that the resistive index on the side of the renal artery stenosis will be normal. And the reason for that is when you have a significant stenosis and it's taking a longer time for blood flow to get to the kidney is actually starving for blood. So the natural compensatory effect would be for the afferent arterioles to open up to provide collateral flow. And so in those situations, what we typically see is that you have an acceleration time that's greater than 0.07 seconds. You have an abnormal waveform pattern with an absent ESP. However, your resistive index is usually going to be normal. However, on the contralateral side, you will see that the resistive index would be abnormal, because in this situation what happens is that the resistive index, the degree of resistance actually increases everywhere else in the body. So this is an example of an abnormal indirect method. First of all, in the kidney you can see that there's very little color. We only see just a couple little dots of color. Right away we know that the kidney does not have very good perfusion. We put our sample gate in the segments where we're going to be looking at flow, and you can clearly see the change in the waveform pattern is very blunted, very dampened. There's no early systolic peak present. When we try to measure a rise time, we see that in this example it's delta T is 0.135 seconds, so it's very prolonged as compared to the normal values that we've previously indicated. So these values combined with very little flow to the kidney itself would indicate that this patient has a significant renal artery stenosis at its origin, greater than 60%. Now the problem with this particular technique is that we cannot differentiate a total occlusion from a significant stenosis, but that's really not the issue here, because all we care about is the stenosis greater than 60% or not, which would indicate that this may be a potential source of that patient's hypertension. The important factor in doing the indirect method is that you need to take samples at 3 segments of the kidney, the superior, mid, and inferior aspects of the kidney. You'll want to compare your waveform characteristics and your acceleration time measurements and resistive index measurements to one another within the same kidney, and then you need to compare that data to the contralateral kidney. They should be symmetrical in waveform characteristics as well as measurements. If there's a discrepancy from side to side or from one segment from the ipsilateral kidney to the other segment, then that's an indication that the exam is abnormal and that the patient may have a renal artery stenosis. In the event that you have equivocal results, then you may want to move forward and try to evaluate the main renal artery at its origin. But if you're finding that all your values are symmetrical, your waveforms are symmetrical from side to side and from within the same kidney itself, then you can be pretty confident with your results. Now, one of the questions that usually arises is the value of resistive index. And the resistive index is basically being used to evaluate the flow characteristics. Do I have flow that occurs throughout the cardiac cycle? As I mentioned before, on the side with the significant renal artery stenosis, you usually will have a low resistive index due to the afferent arterial dilatation, and then we'll have a high RI on the contralateral kidney. You also may have a high resistive index in other situations. Contralateral renal artery stenosis is obviously the first thing that we think of. However, there's some other conditions that may cause the patient to have a high resistive index. That would be urinary obstruction, hydronephrosis, diffuse small vessel disease, or diffuse parenchymal disease. And that's where your renal ultrasound examination has a great value to you, because once you've already scanned the kidney initially, you have a good idea whether there's any renal abnormalities in terms of hydronephrosis, any renal masses that might be present that may be a source of causing the abnormal resistive index method. So if you've already looked at that initially, then you can rule those causes of the high RI out. And so if you've got a high resistive index on one side and it's a normal sonogram otherwise, then you're going to be thinking that the contralateral side may have a significant renal artery stenosis. So just like other areas of ultrasound, it's a matter of taking all the pieces of the puzzle and putting them together and determining whether they correlate together. And in the case of the indirect method, if they don't correlate, then that would be an indication that you may need to move on and do the more extensive evaluation using the direct method. But typically, the indirect method is a little bit quicker. It has less pitfalls in terms of having to work around bowel gas and angle of incidence issues. And so if you can start out with that and get pretty good results as far as seeing that your results are very symmetrical from side to side, then you can be pretty confident that you're getting accurate results. Where you'd want to move on to the direct method would be if you're having a difference from ipsilateral kidney or contralateral kidney. One of the questions that I typically get is, do I need to do both examinations? And of course the answer to that would be no. What I have found is in that most labs, that if they are comfortable with the direct method and they're not familiar with the indirect method, they will do both examinations initially until they can get some good QA performed and demonstrate that they're getting accurate results with the indirect method. And once that's been achieved, then they will move on to the doing the indirect method first and only doing the direct method as a way of concluding that there is a significant stenosis if the results are equivocal. Now, what I'd like to do is take just a moment here to show you a quick video before we end and just show you a normal examination. What we're showing you right here is the abdominal aorta. This is the celiac artery and the superior mesenteric artery. See, the waveform is fairly high resistance with very little diastolic flow. And in the distal aspect, we actually get a triphasic waveform. You'd be taking your velocity measurements in the proximal segment, so you may see more diastolic flow. This is the left renal artery. This is the abdominal aorta, the left renal artery coming off of the aorta here. It's color encoded blue with flow going away from the transducer. You can see that it looks like flow occurs throughout the cardiac cycle. It gets lighter in systole and darker in diastole. Just above the renal artery is the left renal vein coursing over the aorta, but underneath the superior mesenteric artery. As we move over towards the patient's right, again, abdominal aorta, and this is the right renal artery, again, color-encoded blue, because the flow is going away from the transducer, coursing posterior to the inferior vena cava. Again, we see that flow occurs throughout the cardiac cycle, lighter in systole, darker in diastole, indicating that it's going to be a low resistance pattern. And when we place a Doppler in there, we see that the waveform is a low resistance waveform pattern with good flow during diastole. We have a nice normal waveform pattern with no window filling. And this is just looking at the renal artery and the renal vein together. So a low resistance waveform pattern is what we're looking for, flow throughout the cardiac cycle. This is the banana peel sign, the abdominal aorta. This is the right renal artery coursing posterior to the IVC, and the vessel color encoded in blue is the left renal artery. This is the liver right here. Right renal artery, left renal artery, color encoded in blue. Again, an ideal view to look at the origins of the renal arteries with an angle of incidence of nearly 0 degrees. So kind of eliminates that potential pitfall with the direct method. Just sending looping through this at this point, just showing you systole as lighter colors. And this is just putting the color over the kidney itself, just showing you the normal perfusion to the kidney. We can see that flow extends all the way out to the periphery of the kidney. And as we move, we just move to different segments, and notice that there's very little liver in view here. Almost the entire image is taken up by the kidney, and that's what you're trying to do so that you'll get better color flow. And then when we drop our Doppler in the segmental renal artery, and we take a waveform there, and I believe one will be coming up momentarily. And again, we see the normal waveform, low resistance. Here's our early systolic peak, second systolic peak, and nice diastolic flow. And again, window filling is not an issue here, and we measure an acceleration time from end diastole to the early systolic peak. And we also can measure an RI, which is 0.56 on this patient. So this is just kind of a quick overview with real time to give you an idea of what it looks like in real time and the waveform patterns that are associated with normal patients. As with all aspects of ultrasound, the renal artery examination is a very complex examination. It has a fairly long learning curve to it. The only thing that you can do is basically try to get as many people in to perform the exam on as you can. And the more patients that you do, you'll see that the time it takes you to do the examination will begin to decrease. Your proficiency and your confidence level will increase, and your accuracy will also increase over time. Usually it takes anywhere between 50 and 100 examinations before you get to that accepted level of proficiency, and it's just one of those situations where you need to practice. But I would count on initially anywhere between an hour and 2 hours per examination, and then you'll see that time kind of decrease as you become more proficient.